So hi everyone, we're at the top of the hour. We have 19 participants. Do you want to give it another minute or two, or shall we start?
I think
all
you
our
can
speakers
start.
are in. We can start, right? And because it's housekeeping, we can be able to move along as we are getting joined by other people. So good morning, good afternoon, good evening from wherever you are joining us from. My name is Benda Kithaka. I'm joining you from Kenya, Nairobi. And I'm delighted to be hosting all of us today. And I'm delighted that you're joining us, all of us today, for the 16th Africa Cancer Research and ECHO, which is every 2 weeks we meet together and we get to discuss topical issues relating to cancer control practice in Africa. And I'm delighted that today we're hosting distinguished guests from the WHO who are going to be speaking to us about the implementation of the global cancer initiatives by the WHO implementation in African region. We're hoping that this session will provide us with an overview and an update of what the WHO global cancer initiatives, cervical cancer, breast cancer, and childhood cancers, what the overview is, what those initiatives are. We're also hoping to be able to identify regional priorities in African region and local considerations that we can take into adapting and aligning to the global strategies and the global targets. I'm delighted to welcome you all. A quick note, let's remember to mute our microphones if we're not speaking so that we can all have a friendly and nice atmosphere for this call. If your bandwidth permits it, put your video on. It makes it an exciting thing to get to see your faces as you're also asking your questions and as we're chatting. Use the chat at any time. It's good to know that we're engaging, and also for our speakers, if they say something that's really burning for you, you can note it on the chat and we'll be able to pick it up as question and answer sessions as we go along. Feel free, we will be having a 25 minutes question and answer session at the end of this, the speakers. And so delighted that we'll be moderating that and we can be able to ask as many as possible. And lastly, this session will be recorded, and it's so that we're able to share with the larger global team and the larger team that also joins these sessions, and for the ones who may not be able to do so, it shall be shared with all of us. So once again, I welcome all of you to this session. We are tackling the global WHO Global Cancer Initiatives. To start us off, we will have Dr. Roberta Ortiz, who is a medical officer and the focal point for Global Initiative for Childhood Cancer at the World Health Organization. She sits at Switzerland, but also supports the team in Africa. Dr. Roberta will then be followed by Dr. Adile, who is the technical officer for cancer in the World Health Organization Afro region. After which we will have Dr. Sharon Kapambwe, technical officer based in Zimbabwe, WHO, and she will also be talking to us about cervical cancer. After which we will have Dr. Ben Anderson. He's the medical officer, Cancer Control World Health Organization based in Switzerland, and he will be speaking into the breast cancer initiative. And lastly, we will have Dr. Philippi Rutberg, who will be speaking to us about cancer control and the economic case for cancer prevention. And so without further ado, I will invite Dr. Roberta Ortiz, who will be taking us through 5 minutes of her slides on childhood cancer, after which we will have Dr. Dile speaking to Childhood Cancer Initiative in African region. Welcome, Dr. Roberta.
Thank you so much, Benda, for your kind introduction, and good morning, good afternoon, and good evening to all. I'm going to start sharing my slides now, and I want to thank you for giving me the opportunity to share with you today an overview on the Global Initiative for Childhood Cancer. But as also you mentioned, I'll be sharing this presentation with my colleague, who is the Cancer Control Officer responsible for West Africa, Dr. Dile Isumura. So as many of you know, the Global Initiative for Childhood Cancer was launched back in 2018 with the target of improving childhood cancer survival worldwide to at least 60% by the year 2030, aiming to save 1 more million lives of children by 2030. As we all know, we are aware that childhood cancer represents a significant public health issue. There is a great inequity, health inequity in survival, with a survival gap between children diagnosed in high-income countries and children being diagnosed in low and middle-income countries. We know that most or more than 90% of children who are diagnosed every year with cancer live in low and middle-income countries, where the access to health services is not equal, and there are difficulties for diagnosis, for access to treatment, and this results in the very poor survival rates as compared with countries with high resources. So in 2018, to target this health inequality, the Global Initiative for Childhood Cancer, together with implementing partners like St. Jude Children's Research Hospital and the growing childhood cancer community, launched the Global Initiative for Childhood Cancer with the operational approach of the Cure-All. And on the road to achieve this ambitious target of increasing survival rates to 60% worldwide, actually 62 countries in the 6 WHO regions are implementing the initiative and the Cure-All operational approach that is based in 4 pillars and 6 enablers that are represented in the Cure-All acronym. This framework for action supports the member states by outlining which key interventions are needed to scale up the country's capacity to provide quality services for children with cancer, but also contributing to the formulation of their national policies and plans and to advance implementation and monitoring for improvement. I will be sharing some slides after this, so you can also have the link to the Cure-All framework document. So in order to implement this initiative, 4 coordinated steps or phases are required for the 4 pillars and the 3 enablers. So these are called the phases for implementation. So the initial phase is an assessment, which will provide a snapshot of the current country state capacity to provide services for children with cancer, and both at national and facility levels. And for this, at WHO, we have designed, as part of the Cure-All technical package, an assessment tool that will support the member states in this initial evaluation or snapshot. Then it will be followed by a planning and costing for implementation, which will be conducted through a mapping of the multiple stakeholders that are active pushing the childhood cancer agenda and trying to engage in a collaborative approach to mobilize resources required to implement the prioritized country activities from what I showed before. It is the Cure-All 10 core projects. Then it will be followed by the implementation phase itself, well, through the effective collaboration among the multiple stakeholders, including the government, the health facilities, the professional organizations, the parents, and the patient support groups, as well as NGOs. The mobilization of stakeholders across different sectors will be supporting government efforts to accelerate progress. And this has been, in many of the countries in the 6 WHO region, the key for success for actively engagement in the implementation of the Global Initiative for Childhood Cancer. Finally, but not less important, is monitor to modify. So countries will select outcome measures to monitor for progress according to their capacities. From the WHO headquarters, we are currently working in developing a monitoring and evaluation framework based on the Cure-All operational approach. And this will be also piloted through the regional networks in the Global Initiative for Childhood Cancer. This is also part of the technical support that WHO, through the 3 levels, it's providing to countries that are actively engaging to monitor the performance of childhood cancer programs at global level, but knowing that specific regional adaptations will be needed to identify program needs, focusing on quality improvement and research priorities. And that will now give the floor to my colleague, Dr. Dile Isomura, who will be sharing with us what is the current state of progress in the Africa region. Over to you, Dile.
Thank you, Roberta. So this year in African region, we made some progress. As you see at the beginning, we have only 3 countries, and now we have more than 3 countries in, so 12 countries, some in dialogue, as you said, and some working. Okay. Okay, so now we have 12 countries. 2 countries are in dialogue, and we have 4 countries already working on the initiative. It's Zimbabwe, Zambia, Senegal, and Ghana. And we have 6 countries which are actively working on the QROL activity, the GICC activities. So next, please. So this year we try with to discuss with the country for the prioritization of some action, some activities on governance to define and accomplish objective and output with them in the aim to strengthening and linking registry, population-based cancer registry and hospital-based cancer registry for childhood cancer. We are working on supporting dialogue among the other countries, and to set up, to help them, to support for regional center of excellences for the training of the healthcare providers, and for national cancer strategy development. So we have some of the countries, Zimbabwe, Zambia, Senegal, Benin, which are working on their NCCPs, focus on childhood cancer in the region. And for you are coordinated in at country level action, in the region action, and we will align country-specific strategy with regional priorities. So one of the priorities is to implement cancer workforce training package. So some of the countries are already established, develop some guideline for cancer childhood cancer training. We have Zimbabwe, Senegal, and Zambia, which are already working on it, and Benin. Yes. Okay.
Thank you so much,
Okay,
Dile.
thank you.
Thank you. So yes, we try to summarize, as Dile presented, the main activities, as you have seen, that are similar across different countries in the region to align their country-specific priorities with regional priorities. This has been a way to progress in the implementation of the initiative, as there are now 4 regional networks, particularly in the Southeast Asia region, and the PAHO. There are 2 sub-regional networks implementing the Global Initiative for Childhood Cancer in the Caribbean and in the rest of Latin America, and also recently in the Eastern Mediterranean, where 6 countries are advancing in the implementation of the QROL through a call for proposals to identify prioritized areas within the QROL core projects. So from the Global Initiative for Childhood Cancer, this has been what we wanted to share with you all today. Over. Thank you.
Thank you so much, Dr. Roberta and Dr. Dile. Those were very insightful conversations that you've had there. And listening to you, I had, in terms of both the structure of the childhood cancer initiative, as well as the cascading to the African region that has been presented, there is a very clear methodology that has been used and also very clear flow of the activities that ought to be adapted. We'll now go to Dr. Sharon Kapambwe, who will present on the cervical cancer initiative. Dr. Sharon is a technical officer at World Health Organization African region. For more about their various, we have their profiles also attached to the program, so you can be able to review that. Sharon, over to you. Thank you.
Thank you, Bender, and good to see you all. Remembering many years that I was part of this. Now, I'm not sure why I can't see my, just wait. I want to put it in slide mode. It's still coming out in, no. Sorry, Mishka, about that.
No problem.
Can't see my bottom part of my screen.
You can also on the top left where, yeah.
Ah,
Yes,
found
there,
it.
try that.
Thank you. Good afternoon, everybody. Sorry about that hiccup. My name has been introduced. I'm Dr. Sharon Kapambwe, Technical Officer for Cancer East and Southern Africa for the WHO Afro region. I am sure most of us, if we're not yet singing this song, we should be, the global strategy to accelerate cervical cancer elimination. That was launched in 2018. Actually, the call to action was done, and finally the strategy was launched in 2020. And the proposed elimination thresholds, what we're working at currently, and we are talking about elimination as having an age-adjusted incidence rate of less than 4 per 100,000 women. The 2030 targets that have been set in the global strategy are 90% of girls fully vaccinated with HPV vaccine by 15 years of age, 70% of women are screened with a high performance test by 35 and 45, and 90% of women identified with cervical disease, pre-cancer or cancer itself, receive treatment and care. And of course, this is also a contribution to the SDG 2030 target of reduced 3.4 of reducing premature mortality from NCD by 30%. And also further, the African region has a framework for the implementation of the global strategy to accelerate the elimination of cervical cancer as a public health problem. And this was agreed on the regional committee, which was held, and your ministers of health endorsed this framework. Looking at HPV vaccine and where are we? So basically, currently we have 23 countries in the Afro region, the WHO Afro region, which is 23 out of 47, giving us about 49% of the countries having HPV in the national immunization program. And you can see what is happening. You find that most of the countries that have actually been able to include HPV vaccination are in the East and Southern Africa. And we are glad that now we are also seeing West Africa and Central Africa beginning to include HPV vaccine. And one of the most thrilling or a good thing that has happened is seeing the one dose recommendation that was done by the WHO SAGE group this year in April. When we come to screening, and we look at the ever in a lifetime screening coverage, and this is 2019, of women aged between 30 to 49 by country, you will see that the coverage is less than 70% in 126 countries. And you can see that all the African countries have a screening coverage of less than 70%. The closest we have is we have South Africa, as you can see, having between 50 and 69. And I know that even Cabo Verde as well has that screening coverage, and we have Botswana as well. So the rest of the countries, as we are looking at the 2030 goals, on the continent, all the countries, none of the countries has attained 70% coverage. On top of that, I wish to add that when you look at HPV, as you saw in the first slide, 70% of women screened with a high performance test like HPV vaccination, you will see that on the African continent, most of the countries actually have not yet endorsed HPV vaccination as a national screening test. So if you find that some countries have more than one screening test, but that means that there has to be a transition by most of the countries from currently what they're using to a high performance test like HPV DNA testing for us to be able to attain the 2030 target. And if we come and look, there's a treatment part that is missing or went elsewhere. If we come and look at treatment that we have, you will see, I can speak to that, that you will see that in our countries, we have 28 countries, about 52% of the countries having radiotherapy facilities, but you must be cognizant that some of these radiotherapy facilities are actually in the private sector. And there could be countries that are actually having more than one, and there are countries that are having. So when you hear 28, you should remember that some of these 28 are solely in the private sector, and we have to talk about issues of equity as well. When we look at surgical oncology, what has been studied recently is that you find that most of it is still very centralized. That means that most of the women have to walk long distances to be able to access that. I took some of the priority interventions and actions from our framework for implementation that we have that I talked about. When we look at some of the governance issues, we have more than this, and I would encourage you to have a look at them. If we look at governance, we're really looking about issues of assessing the needs and mobilizing resources. Where are we? Where are we going? And we have been doing that. First, we did have an assessment of 6 countries. Then where we looked in depth about where we are and what resources needed to be mobilized. And we also look at defining the cervical cancer management package to be included in the UHC benefit package, and some countries have started including that. And one of the governance issues is ensuring that partnership and intersectoral and multi-sectoral collaboration. We see a lot of efforts going in, but without coordinated efforts, that seems to be a problem. In prevention, we're really looking at having and developing and implementing sustainable supply of HPV vaccine. The 1 dose is a welcome, particularly for our region. And we need to improve communication and social mobilization for HPV vaccine. We have to expand service coverage. We have to ensure affordable supply of high performance tests like I talked about, and even the coverage of that high performance test. In terms of treatment, it's the referral pathways that needs to be established, and to be people-centric. Linkages must be throughout the continuum of care. We need to start investing in anatomical pathology services. That still remains a huge bottleneck on our continent, expanding surgical oncology capacity and ensuring curative treatment by investing in radiotherapy. And finally, like we are talking today, some of the priority actions include promoting research and development. Please, for further resources under the WHO, we have the Cervical Cancer Knowledge Repository, and there is, these slides will be shared, of course, and we will find a lot of materials or resources that can help your country, whatever you're looking for through the continuum of care for cervical cancer. Thank you so much.
Thank you so much, Sharon. That was quite insightful as well. And thank you also for the timekeeping. I'm liking this panel that we still have the Q&A that's coming up. Next, we're going to have Dr. Ben Anderson. Dr. Ben Anderson is going to be speaking to us about the Breast Cancer Initiative. He's with the WHO as a medical officer in Geneva. Please, welcome.
Well, thank you very much, Benda. I appreciate the opportunity to present our project today. The Global Breast Cancer Initiative is the newest of the 3 initiatives, and I'll be providing a description of the framework of our program. Breast cancer is the most common cancer globally, and breast and cervical rival each other in sub-Saharan Africa. Our goal is to reduce breast cancer mortality by 2.5% per year, which would save 2.5 million lives over a 20-year period. There are 3 pillars to the initiative. The first pillar is health promotion for early detection, which is an educational initiative based on the concept of how do we stage shift so that enough of the cancers are early stage for management. The second pillar is timely breast cancer diagnostics, proving that it's cancer. And the third pillar is comprehensive breast cancer management. Conceptually, what we're doing is marrying 2 different ways of looking at the problem. The public health sciences way, where we're looking at populations as a group, and the clinical way in which we look at patient management. If you see here on the left, we have successfully reduced breast cancer mortality in high-income countries. And the question then is, how do we achieve the same mortality reduction in low and middle income country settings that have some, but not all of the tools that were available in those prior settings? And the idea is that we want to use the same framework that they in fact did use in high income countries with those 3 pillars. The first pillar, where the patient enters the system with disease, and we need to have adequately early stage disease. The second being proving that it's cancer and distinguishing who does not have cancer, because in early detection, 10 women with a breast lump, 1 of them will be cancer. And the third interval, that management interval. So looking at that first interval, health promotion for early detection. Health literacy throughout the system is essential. Women need to understand what breast cancer is, what early signs of it would be, and why they would come in for evaluation. Linking this to cervical cancer screening is logical for the reasons that was laid out by Sharon. The second equally important educational initiative is education of the providers so that they recognize early stage disease when it presents to them. And therefore, we need to develop educational materials, both for the public and for the health system, to promote that early detection. The goal is to get 60% of the invasive cancers being stage 1 or 2 at diagnosis. And that is not the case in the great majority of sub-Saharan Africa. The second pillar is timely cancer diagnostics. Diagnostics means using clinical evaluation, imaging, needle sampling, and tissue pathology to sort out the benign from the malignant. And the tools that are used to do this are actually tools that would be considered standard today. We do need to have pathology. This is often lacking. And we recognize that we could use standard methodology, such as immunohistochemistry, for determining tumor markers, but novel leapfrog technologies are equally important, especially if they can be done in ways that are more practical and affordable. But we also need to think about the system. How do we navigate the patient through the system? The goal is to be able to make a diagnosis within 2 months of presentation. The reason 2 months is the right time period is that at 3 months, that's when we start to see mortality gradually drift downward, upward. And so we need to be able to have our systems operate in this way. The third pillar is this comprehensive breast cancer management. We know that we have to be able to create multidisciplinary plans involving surgery, radiation therapy, and systemic therapy, and we need to be able to get the patient all the way through treatment. We have much written about this. This is all standard care. It's based on the biology of the disease. That patient navigation is essential, and measuring outcomes is equally important. If you don't measure your outcomes, you won't know if improvements have taken place. But we cannot forget about the women after they've gone through treatment. They need to return to the community. We have to think about financial toxicity and being able to support them after this treatment. Our goal is to get 80% of women through treatment to completion. We now have data from sub-Saharan Africa. This was generated in the ABC-DO project, where 5 sub-Saharan African countries had data collection through nurses followed from cancer diagnosis in patients in several centers. And what you see on the left, the blue bars, is how countries are doing in terms of 3-year survival. The red bars indicate how much improvement would take place if we could address that therapy that being taken through to completion. If we could stage shift, if we can get that downstaging of disease. The green bars illustrate how much would take place. And equity, we have to have access in order for this to work. And so it can't be just theoretical. Just touching on the data of treatment completion, the ABC-DO project published data from these different countries. And what you can see is it's actually the minority of patients that make it all the way through treatment, as illustrated by the green bars. The fraction of patients that do not complete treatment because of the multiple reasons that that can take place is a really unacceptably high number. And we have to be thinking through how to do this. If we just treat patients partially, that's the worst of all worlds. They get the side effects without the benefits. Thank you very much for your attention. I'd like to acknowledge the many contributors at WHO that are making this work possible. Thank you.
Thank you so very much for that presentation, Dr. Anderson. And listening to the three presentations, it's very clear on what I like to call the 3 Ps in cancer practice, which is on policy level, at the patient level, and also at the practice, which is about the treatment. For all the 3 initiatives we've had from the specialists and the experts, and the question is, how do we prioritize, where do we put the resources, and especially in low resource settings, such as ours. And I'm delighted that we're joined by Dr. Philip, who will be speaking to us about investment case for cancer control, because then it's important we know what do we need to be looking into in prioritizing. Dr. Philip, take it away. Thank you.
Thank you, Benda. Thank you all colleagues that are here today joining us. Do you hear me well? Great. So to me, it's the task about discussing what Ben just mentioned about how do we figure out the investment case for cancer, considering a whole products that Ben Anderson, Roberto Ortiz, Dilly, Sharon, and our dear colleagues mentioned about the Global Breast Cancer Initiative, the Childhood Cancer Initiative, and also the Cervical Cancer Initiatives. We know that WHO has a mandate to support countries, and we are now following the mandate that relates to providing financial considerations for countries. And in this regard, we know that only 9% of the countries have financial considerations to implement these optimistic but also feasible goals that our dear colleagues just mentioned before. So in the end of the day, it's not dissociated costs from the outcomes that we are aiming to reach. And in this regard, we don't want to appropriate ourselves to tell the countries what to do, but how can we support countries reaching the targets that Ben, Roberta, Dilly, and our dear colleagues mentioned that are feasible to reach using the normative documents that the country already have. And here you can see the guidelines from the country that we could use to frame this language. So what we developed through the past years was a tool, the UN tool, that takes into consideration inputs related to disease burden and to capacity of the healthcare system, public health programs and interventions, the cancer management, in-unit costs, and workforce. So we address the whole capacity of the country to the challenges to provide cancer care in a quality and timely manner. In this regard, again, if we come up with a colonized language that we know exactly what the country needs, we will fail again, as we've been failing over the past years. So how can we do better? It's listening to those who are in the country, who are working with patients that know the healthcare system. So the first step for using this tool is validating the information that we obtained from the official databases from IARC, WHO, IEA, and also the country databases. So we review all the cancer burden and the capacity of the system in the epidemiology and the policies to make sure the inputs that we have in the tool are really aligned with the reality of the country. And this process goes beyond numbers. It comes up with a qualitative discussion that whenever we have different levels of leadership increases a lot the engagement and making sure we can adapt the tool according to needs. Here you see an example of Mozambique, whenever different levels of leadership colleagues were involved in this workshop, and were several different workshops where we validate this data and had the opportunity to see how the tool should be adapted. As an example, the tool didn't have Kaposi sarcoma included, so we made sure include it according to their needs, and also 2 more tumors. And this tool is evidence-based, which means that the health impact related to what we find also is aligned with the best literature existing. So we can understand what are the considerations involved to investing on cancer. So we have a great plan that has been aligned with the initiatives. We provided all the discussion around it, and we should prioritize considering our current capacity and our capacity of investment. So how to make best choices? As I mentioned again, and I'll repeat, we must do a quite nice assessment to understand what are the capacity in terms of equipment, consumables, and training. And all this data related to the consumables existing, the equipment, the medicines are validated in the field. And we frequently identify the bottlenecks to reach the goals that we developed before whenever discussing with our colleagues, which means that where should we prioritize whenever we identify that every country has a different need. And we see that workforce is an incredible bottleneck for investment. Whenever almost 60% of the costs, shared costs for a low-income country usually are related to human resources. We are already having to spend on human resources. How to make this better is to train the professionals to deliver what Ben, for example, just mentioned, or Roberta. How can we identify early the patients or earlier the patients than we're doing now? And we have feasible targets. It was mentioned here before. We have to identify at least 60% of the patients stage 1 and 2. So we should monitor on the primary healthcare level how we're performing breast cancer examination as a fundamental component for clinical breast examination of the early diagnosis. And here we try to project on time according to what we defined as the main drivers to reach the health impact that we defined. So we will increase coverage, we will increase complexity of treatment, we will invest in workforce. It's not yes or no, but when and how. And you see here that it is data-driven. I will try to explain in more details. If you take 2 different decisions about expanding coverage by 1% or 2% in a year, how much that would cost additionally, and how much lives we will save a year in a time horizon 5 or 10 or 20 years. If we increase now early diagnosis and project the screening implementation in a timely manner, that we see that we have a better investment for money in the initial phase and setting the stage to increase the capacity of screening later on. What are the considerations in terms of lives gained and the expenditures? So again, it's not about yes or no, but how, when, that will define the investments, and what are the needs that we will need to provide the country to reach these goals, because it's not about money, it's about investing in people, in equipment, and medicines. So this is about the tool. It's a prioritization tool that will frame the investment beyond money, beyond costs, also including what is needed to reach the goals. But what's the value for cancer control beyond the lives that we aim to save, and what it represents in the end of the day? Because we've been facing so many negative messages about not investing in cancer, but let's provide a positive message to the society. Whenever I invest in cancer, and we are now able to discuss securing funds to cancer, which means putting cancer in the agenda. So whenever we put the cancer in the agenda, secure funds and project investments, we can monitor, which is important word that Roberta expressed it very well. We can improve engagement, which also Dilly mentioned, and we can set up targets that Ben Anderson mentioned here to reach the goals that we aim. And in this regard, whenever reaching these goals, what are the value of investing on cancer? We can see here societal gains, which means the increasing healthcare, reducing healthcare expenditure, increasing life expenses, becoming people more healthy. But also, we also consider the labor gains of investing on cancer, which means the increase of workforce participation. Whenever we are not losing people during their workforce age capacity to increase the revenues for the state or in the national level, and in boosting the GPD. So more than investing in health, we invest in the society. So here we see three different dimensions: the health gains, the societal gains, and also the labor gains related to investing in cancer, which means that it's much higher than we expected the value of investing on cancer, specifically because cancer now is the second or first leading cause of death in so many countries. So to finish this presentation, I'd just like to acknowledge one important core value of this tool, which is engagement, feedback, and acknowledging that language and culture plays a major role. This is a tool that aims to frame the dialogue of how the countries see as the best way to prioritize investment. It's a dialogue that makes this tool works, and how to monitor progress to implement, and is data-driven discussions that, as we mentioned, we should be able to monitor and keep assessing. And in this regard, we will face some issues along the way and formulate the hypothesis why we are not addressing and why are perhaps failing on the way, and how can we do better with the money invested. So the country might find a solution to adapt in a sustainable manner. That's the tool about. It's about increasing our capacity and here potential outcomes that we might have from the tool, which means that we are being able to generate our own data and program impact, promotes routine review and synthesis of the available data, improving the dialogue, as I mentioned, to define dialogue and priority settings, enabling national planning with key international partners, and in the decision-making process, promoting coordinated cancer implementation framework, enabling multi-sectorial dialogue with partners and donors, being the donors internal or external sources of investment. And lastly, advancing in health science research, which is quite important whenever we want to define what are our current epidemiology and how can we do better in the implementation research agenda. So we identify where are we failing and how do better, producing scenarios to establish best practice. The tool now is being converted from Excel to Python to make sure the user might use it by itself and do not rely on us all the time. So you come up to us and say, we are facing this trouble, we are monitoring this, and we see that now we should reinvest this way or that way. So I'd like to acknowledge all here, our colleagues that now join in this call, to make sure we want to have a more sustainable environment and make the change in need. Thank you so much for the opportunity.
Thank you. Thank you so much. And we were very ambitious in putting 5 experts to take us through 3 very key initiatives from the WHO. And I think we've learned quite a bit from this call. I've noticed we are now in the question and answer session. I've noticed a number of our colleagues have posted resources on the chat that can be utilized to take further the information that we've gotten. Yes, the slides will be provided as PDF, especially so that you can use them as reference. And we're also recording this call so that we're able to also get further information from it. Now, we're going into the question and answer session, and to kickstart us, we will have just about 10 minutes of Q&A. And so to kickstart us off, I would like to ask of Felipe, you've just finished in taking us through what is the sort of prioritizing, what are the things that we ought to be looking into when we are prioritizing. But if you had a magic wand, and knowing the African region, the many challenges that have been mentioned in terms of policy and adaptation of the initiatives, going into regional practice where we're seeing patients going very long distances to access treatment, and that becomes a barrier. If you had a magic wand and you say, for the African region, if we were to implement, these are the 3 things you would look into for you to be able to better prioritize. What are those 3 things you would take us through?
So your
or 1
question,
or 2.
Yeah, your question is quite challenging. I think it's the 1 million question. We should prioritize it. But I will start with an important issue that we've been identified, which is lack of access, not only to treatment, but also diagnosis, as you acknowledge it. And for sure, distance is an important component of that, but how to increase coverage. So as I was mentioning regarding to our goal here, our target goal is understanding how can we increase access, being it related to cultural barriers for screening, for whenever a woman does not access the screening because she's not aware of her body, or she doesn't have enough education, or the healthcare professional is not trained to do the clinical breast cancer examination, for example. So this relates to access also. But I would like to work, if I could have one answer to you, is about how to increase coverage. More than increasing complexity of treatment, do the right diagnosis. Any physician that doesn't do a proper assessment for diagnosis will finish and end up losing the patient and doing the right diagnosis and the wrong treatment. So to do a correct treatment, I will start with a proper diagnosis, which is assessment. How is your health system capacity now able to deal, to understand how can you increase your capacity and efficiency first, and then to provide further investment to increase the coverage or the complexity of the care. That's my answer to you.
Thank you. Thank you so much, Philip. For Dr. Anderson, there is a question on the chat about leapfrog technology that can take us to the next level for breast cancer. And I think it comes in very well from what Philip has spoken into. Kindly, would you like to take that?
Sure. I think that we have to be thinking about where the gaps are. And one of the more significant gap is on pathology, and being able to distinguish malignant from benign, and really importantly, knowing the tumor marker expression. Because if you don't know ER, PR, and HER2/neu, you really can't embark upon the correct pathway. You don't have the map. Immunohistochemistry is very difficult to do in all settings because it's antibodies. You're trying to get it to stick onto tissue, and that's not easy. There's new applications using PCR that appear to be able to give us this information in ways that are much more practical. And one application is actually using the Gene Expert tool, which is already present. I think this is very promising. But the other leapfrog approach that I think we have to think about, much of what we do requires that human communication, that navigation. How do you navigate the patient through the system when you don't have many people that can do this? How could we use cell phone technology that would both provide accurate, correct information to the patient and help them with navigation, help them know where they're supposed to go and how they're going to do this? A lot of people are talking about cell phone apps. I think we need to see how is this going to move forward. There's been nice work done in cervical cancer, and I think there's going to be real progress here. That when people, they think of it as sort of mundane, it's not mundane. It is really essential that we be able to route patients through. Thank you.
Thank you. Thank you so much, Dr. Anderson. For Sharon, the question is, coming from where you were sitting at Ministry of Health, working in the cancer space for cervical cancer elimination, and now at the WHO level, where you're showing us a slide that shows that we are at below 50% across all of Africa for access to screening. What is the one thing that you see countries can support you in ensuring the WHO cervical cancer elimination strategy is done? What's that one thing that you would ask of the people here that they can support for you to be able to support the work in country? Thank you.
One of the key issues that I should mention is about coordination. I talked about one of the priority interventions and action as being, multi-sectoral, intra-ministerial, interministerial collaboration. Coordination is a big issue on our continent. We have many people working in the space of cervical cancer right now in institutions and organizations. But what you find at national and subnational level, even at regional level, is that we are not having cohesive coordination. If they can be coordination frameworks at the level of the nation and making sure that resources in a country are properly marked so that we know who's working where and what they are doing. Only if we know what everybody is putting, then we'll know what gaps are. But we find that there's a lot of duplication and redundancy in the way we're working. So my one word to the people here is to have coordination at national and sub-national levels, which is led by the Ministry of Health. They have to take the governance and leadership of coordination, bringing all the partners to one table, private sector, public sector. Coordination. There has to be a mechanism that is being used on the continent for us to see our gains. Thanks, Binda.
Thank you. Thank you, Sharon. Thank you so much. Coordination, I agree with you. And lastly, I'll ask either Dile or if we can have Roberta respond to this. One of the things you touched on is the low survival rate on childhood cancers. And that becomes a thorn in the flesh, because if we're telling people prevention is better than cure, but all they're seeing is more people dying of the disease that we're trying to prevent, then it becomes hard. So my question to you is, looking at the case examples you showed of the countries that are being fast-tracked to implement, for the countries that are still in the sidelines waiting to be onboarded, what's the one thing you would want them to get started on for preparedness towards implementing this childhood cancer initiative? Thank you. Roberta or Dile?
Thank you so much, Benda. I think I would address it from the perspective of the global, and then perhaps Dile from her experience on the ground. But as other colleagues have touched on this, the main barriers that mark this difference between low and middle income countries, we know, and it's been said here, access to diagnosis. And in childhood cancer is very different than adult cancers and breast cancer, because we don't have prevention. So the key here is early detection. And having strengthened referral systems and having workforce capacity building. You have seen the priority actions that we have outlined. So improving the capacity of the workforce to allow early detection for childhood cancer, because most of childhood cancers are curable if they are detected in early stages. So those are the efforts that have been identified in different regions.
Thank you. Dile, would you like to add something to
Yes, thank you. As you said, Roberta, is good. But what Sharon say is, I think the coordination is necessary even for childhood cancer, because we have many actors working in the region on childhood cancer, but we need more coordination to have effective results. And even commitment, a high commitment for the governance. We need commitment, because as you see, we can have early detection with low resources, but we need the commitment of the government. So the governance is a key for this too, and the coordination. Thank you.
Thank you so much. I think for purposes of time, we are now 6 minutes into the hour. And unless there is a burning question that you can put on the chat as well, and we can be able to address that as we go along. There has been a lot of dialogue that has been going on the chat, and I think it's good, valuable feedback towards this session. Quite honestly, we would need more time for each of the sessions, each of the initiatives, for us to understand it better. But from what I've picked, that we need to think on the policy level, governance, and we need to think about the political goodwill, securing the resources as well as the commitments for these initiatives to work. At a coordination level, resource mapping, to see that everyone who is acting in the space is also looking at how they can collaborate, coordinate, work together with others to avoid duplication and wastage. And that would address the question of economic case for in interventions in cancer control, as has been spoken into by Philippe. And for everybody on the call, it's more of for us to see that today was just to create an awareness and to create a sensitization. But we need to further read into these initiatives, further understand how we can be able to customize them for the local context that we are operating from. And I think this has provided a very good platform for all of us. So thank you so much for our distinguished speakers. This has been quite eye-opening. I'd like to hand over now back to Mishka or Charles Moya to take us to the next level. Thank you.
Thank you very much, Benda, and thank you so much to everybody who spoke today and to all the vibrant discussion in the chat as well. As Benda said, this was definitely ambitious, but very informative. And I think for those of you who are on the general distribution of the Africa Cancer Research and Control ECHO, you know that we are winding up our 2021 to 2022 year. In August, we have launched the evaluation survey. I'm actually going to put it in the chat to remind folks to respond. And this survey is for everybody, both the folks based, the participants within the Africa region, international partners, global partners, everybody, because this helps contribute to the next year. And the reason I'm saying that is also because I think potentially we could think about having a series of sessions for each of you, if you would be willing, from our WHO colleagues to come one by one over the course of the next year, so that we can delve deeper into the really important work that you've highlighted today. So thank you everybody for joining. I will note that our next ECHO session would be, because we are bi-weekly, it would be July 7th. However, we are canceling July 7th's ECHO. Several of you may already know, I'll also post in the chat, there will be a Global Health Catalyst Summit that is taking place on that day, which will include a launch, second formal launch, I should say, of the Lancet Commission on Cancer in Sub-Saharan Africa. So please, you can register and join virtually. There's also an in-person component here in the DC area for anybody who's in Washington. So the next ECHO session will be on Thursday, July 21st. And actually it will be inviting some of the Lancet commissioners from that Lancet Commission piece to speak to the Africa Cancer Research and Control ECHO community. So save that date for sure. And I will turn it now to Amaka, our chair of the ECHO, in case you have any closing remarks, and a big thank you to Benda for facilitating, and to all the speakers. Over to you, Amaka, for the last word.
All right, thank you so much, Mishka. Thank you, Benda, and to all our speakers. I do want to echo the fact that we were really over ambitious and in really putting all five great speakers together. But again, like Mishka said, the call is open for next year's session. We would really like to do a deeper dive. We've touched on so many important issues that we really need to think about if we need to change to the narrative. So I think we are really at the top of the hour, and I'd like to say thank you to everyone who has joined. Thank you to all our speakers. Great to see you all once again. And I think it's bye for now. Bye, everybody. And thank you so much for joining us. Excellent presentations, everybody.
Thank you.
Thank you, Amaka.